Hi there, let's get started with this warm-up review. So this is another long lecture, so we have another short warm-up. First question, what is the classic presentation of a patient with giant cell arteritis? So the classic presentation includes unilateral headache, jaw claudication, and towards the later stages of the disease, you can have even blindness or impaired vision. Next question, in a patient with an elevated alkaline phosphatase, elevations in which other serum lab markers would point toward a diagnosis of liver disease? So this would be our transaminases, AST and ALT, and also GGT, which is gamma-glutamyltransferase. Alright, that's it for this warm-up review. Let's move on to the lecture.
Doctor, kiss me, you fool. But Barbie, I'm your doctor. If only my code of professional ethics didn't forbid it. Oh, doctor. Professional ethics be damned. In this video, we're going to talk about ethics, which on the whole is a 5-star topic. You're definitely going to have some questions on ethics, primarily in the form of clinical scenarios where you have to choose the most appropriate ethical course of action. But in order to answer questions on the ethical scenarios, we need to lay down some general ground rules. So let's start with 4 basic ethical principles that I want you to know. The first basic ethical principle is beneficence. Beneficence means doing good, so we as physicians have an ethical duty to act in the patient's best interest. The second ethical principle is autonomy, which basically means self-rule, the right to choose for yourself. So this includes both patient autonomy and physician autonomy. Patient autonomy means that patients have the right to choose for themselves what's done to their bodies. They have the right to know their options and to choose how they're treated, or to choose whether or not they're going to be treated at all. Then physician autonomy means that physicians have the right to choose what treatments they will or will not provide. But that has to be balanced with other ethical principles. So say there's some treatment that the physician considers unethical. If you consider abortions unethical, you have the right to choose not to provide abortions to your patients. If you consider it unethical or immoral to prescribe birth control, you as a physician have the right to refuse to do so. But that's not the last word on the subject, because we have to balance the physician's autonomy with the patient's autonomy. So in these scenarios, the best thing to do is to refer the patient to a provider who might be willing to provide the care that the patient desires, provided that what the patient desires is medically reasonable and within the standard of care. The third basic ethical principle is non-maleficence. This means that physicians must avoid intentionally harming the patient. First, do no harm, right? And then the fourth ethical principle is justice, which means that physicians must strive to treat people fairly. This means we can't give preferential treatment to one patient over another just because you don't agree with the choices the patient's made in life. Now, it sounds pretty obvious, but unfortunately there are a lot of healthcare providers who are guilty of providing substandard care to patients that are obnoxious or insulting or who exhibit antisocial behavior or criminal behavior. And that's just inherently unjust and unethical. Another foundation of our healthcare system is the right to privacy. Patients have the right for their medical information to be kept private and confidential. And our legal standards for protecting patient privacy are established by a law called the Health Insurance Portability and Accountability Act, or HIPAA. Now, among other things, HIPAA sets the standards for storing and sharing certain types of healthcare information. But there are some circumstances in which confidentiality and the right to privacy are superseded by other needs, like the need to protect some third party. For example, child abuse would be a situation where a patient's privacy is superseded by the need to protect a victim or a potential victim. Child abuse, or even suspected child abuse, is a valid reason to ignore confidentiality and privacy in order to notify the state. Disease reporting is another example. States require physicians to report certain communicable diseases to the state health department in order to monitor certain diseases and protect the population at large. So if a patient has tuberculosis, that diagnosis is confidential, it's protected health information, but you're allowed to break confidentiality and share that information with the state health department because tuberculosis is a reportable disease. Schools are also exempt, meaning the school can require a student to provide a record of illness and vaccination status. And that can be shared with other schools that the student may be transferring to. You don't have to get that patient's permission to do that. Employers are also exempt to some extent, meaning an employer can ask that an employee provide a record of illness. They can also discuss with the employee any condition that would affect the employee's ability to work, but employers cannot discriminate based on health matters that do not impact an employee's ability to work. Now, here's a confidentiality scenario that could turn up as a test question. What if your patient's family member asks you to give them information about the patient? Say I ask my wife's doctor what he's treating her for. That's not unreasonable, is it? But my wife has the right to confidentiality and privacy. So the correct response would be to ask the patient's permission before disclosing anything to a family member. You need to ask the patient if it's okay to communicate that information to the family. And be aware that patients can grant permission to share that information with anyone they want, and they can rescind that permission at any time. So if you're having a family meeting and the patient says, well, you can discuss anything about my case with any of my kids, the patient still has the right to change her mind later on and say, don't tell my kids anything, only tell my husband. Again, the patient retains a lot of the power and authority. Another legal boundary placed around our core ethical principles is informed consent. Informed consent means that before you perform any procedure or administer any treatment, the patient has to give consent. That's patient autonomy, right? But on top of that, this has to be informed consent, which means that the patient has to have some understanding of the procedure or the treatment, and understanding of the risks involved and the expected benefits, and also the alternatives to the procedure. And this means that you, the physician, needs to sit down and have a conversation about the treatment. And we usually document this conversation and have the patient sign a form saying we actually discussed all these things and they understand and give their consent. Now, not all patients are capable of giving informed consent. Maybe you have a patient that's demented or delirious or even comatose. Well, how do we determine whether or not the patient has decision-making capacity? Well, for starters, a patient with the capacity to give informed consent has to be able to make a treatment decision and communicate that decision to the healthcare team. So a patient in a vegetative state who can't communicate a choice obviously lacks capacity. The patient also has to be informed. You've discussed the risks and benefits and alternatives, and ideally the patient should be able to repeat some of those things back to you to indicate that they truly understand them. The decision that the patient makes has to be consistent with the patient's values and goals. The decision has to be stable over time. Patients have the right to change their mind, but if they're constantly going back and forth on whether or not to have surgery, there might be a problem. And then finally, the decision is not based on delusions or hallucinations. Then, if you determine that your patient lacks the mental capacity to give informed consent, the decision-making responsibilities fall to some surrogate decision maker. And this is called substituted judgment, where you substitute someone else's consent in place of the patient's consent. But the idea is that the surrogate decision maker should decide whether or not to give consent based on what the patient would want, as if the patient were making the decision for himself or herself. Well, that sounds great, except how on earth do you know what the patient would have wanted? Well, this is what advance directives are for. Advance directives are instructions that a patient gives in advance about what kinds of things they would or would not consent to. So there's an oral advance directive where the patient has told people orally what he or she would want. There's also a written advance directive, which is also known as a living will. Now, these aren't necessarily binding the way someone's last will and testament is. Ultimately, it's up to the surrogate decision maker to follow the patient's wishes as outlined in the advance directive. And then, how do we determine who that surrogate decision maker is going to be? Well, one way is by legally assigning someone durable power of attorney for health care to make those decisions. That's completely separate from the advance directive. And in most states, if the patient hasn't assigned power of attorney, there's a legally established succession of surrogates, usually beginning with the patient's spouse. If there's no spouse, then it's the adult children. If there's no spouse and no children, then it's the patient's parents. If there's no parents, then it's siblings, and so on. Now, what about getting informed consent for minors?
In general, treating a minor requires that you get informed consent from the minor's parents or legal guardians. But there are some exceptions to this general rule, scenarios where you don't need parental consent in order to treat a minor. So you still need the patient's consent, the minor's consent, because of patient autonomy, but there are scenarios where the minor would be able to give consent for himself or herself. One of these scenarios is a patient that's at least 16 years of age, that's living on his or her own and managing his or her own finances. And in most states, those individuals are considered emancipated minors. Treatment of any STDs would be another such scenario. If you have a minor coming in with an STD, you can treat that patient even though the patient's parents may not be there. Minors can generally be treated for pregnancy without their parents' consent. Now, abortion is a little trickier. In some states, you do need parental consent to terminate a pregnancy in a minor. In other states, you only need to obtain consent from the minor patient herself. Treatment for drug addiction or dependency is another situation. A treatment for the child of a minor. So if you have a 17-year-old patient who's a mom, that 17-year-old minor parent can give consent for her children, even though she herself is still a minor. Another scenario would be a minor serving a sentence of confinement. So if you have a patient in juvenile detention under the supervision of the government, that's a scenario where the parents don't necessarily have to give consent. And then obviously, in emergency situations where parental consent is not available, you're able to go ahead and treat the minor. Let's talk about the kinds of specific ethical situations that you might see on your exam. First Aid has an entire page of ethical situations that you can read, and I suggest you read through those on your own. The tricky thing about ethics questions is that you can usually eliminate 2 or 3 of the answer choices as being incorrect pretty easily, but then you're left with at least 2 that seem equally right, and it's kind of hard to tease out why one's going to be better than another. I would generally recommend that you eliminate the choices that you can, and then rather than using up a lot of your time agonizing over whatever's left, just pick one that seems the most reasonable, flag that question for later review, and then just move on. If you have time at the end of the block, you can come back and wring your hands all you want, but don't let these ethics questions eat up too much of the clock. So before we talk through some specific ethical situations, let me give you 2 good rules of thumb. First of all, always be professional and maintain a good physician-patient relationship. Never be insulting or use harsh language. Those rude, uncaring choices are probably the ones you can eliminate right away. And then second, respect the patient's rights, including the right to privacy and the right of autonomy. Remember, the patient can always refuse any aspect of care that they don't want.
Now, with those rules in mind, let's talk through a few scenarios. You can take some notes if you want. First, let's talk pregnancy. This is a good, juicy topic for ethics questions. Say your patient is a pregnant teenager and her parents want you to force her to get an abortion. Well, the children of minors are governed by the minor parent. So this patient has the right to determine what's going to happen with their child. Same holds true if your teenage patient wants to keep the baby, but her parents want her to put the baby up for adoption. It's not the parent's decision, even though the child is still a minor. Now, if it's the teenager who wants an abortion, that's harder to answer because each state sets its own rules and restrictions about when a pregnant teen's parents have to be notified and when they have to give consent. But in general, prenatal care does not require parental consent or parental notification, but most states do require either parental notification or parental consent in order for minors to have an abortion, unless there's some medical risk. So if a minor comes to the emergency room with a miscarriage or an ectopic pregnancy, in those scenarios, you could treat the patient even without her parents' consent.
Another big topic for ethical questions is psychiatric care. Say you have a patient with a psychiatric diagnosis like depression or anxiety or bipolar disorder or whatever, and the patient's seeing a psychiatrist and taking some psych medications. And the patient's clearly improving with this regimen, but now the patient's insurance company says they won't pay for any more psychiatrist visits. So what's going to be your next step? Well, one possibility is to call the insurance company's medical director and explain the situation and try to get the patient approved. Very often when a physician calls to request approval of something and argues that the patient really needs it, the insurance company is going to approve it. Another possibility is for you to keep prescribing the medication that the psychiatrist started. And you should certainly document the situation in the patient's medical record. Document that the patient was improving with treatment and document that the treatment was stopped or altered because the insurance company denied payment. Now, what about a patient that's suicidal? Say a patient comes to your clinic and says, I've been thinking about suicide. Obviously, that's a scenario where you need to assess the seriousness of the threat. Thinking about suicide is not the same as planning suicide. But if you assess it and the patient's serious, you would first ask the patient if they would like to be hospitalized voluntarily for treatment. If the patient refuses, then you have the option of getting a judge to issue a mental health warrant, and that's going to involuntarily hospitalize the patient for a short period of time.
Another type of ethical situation you might be tested on has to do with the financial relationship between a physician and a third party other than the patient, such as a hospital or an outpatient surgery center, or maybe between a physician and a pharmaceutical company. Now, in general, it's unethical for physicians to receive any kind of kickback or gift for referring a patient to a specific facility for health care, whether it's a surgical center or an x-ray facility, or even a company that supplies medical devices like powered wheelchairs. And referrals to facilities that the physician has an ownership stake in is also unethical. So say you own a partial stake in a radiology facility. Now you have a patient with a suspected kidney stone who needs a CT scan. Well, you can't preferentially send that patient to your CT scanner. It's more ethical to give the patient a list of facilities in the area and say, here's a list of CT facilities to choose from, and you can choose whichever one you want. You let me know, and then we'll set it up. Because the physician's rather going to profit if the patient does go to their facility, so the patient can't be coerced into doing so. It has to be a completely voluntary act on the patient's part. USMLE and COMLEX now include questions on quality improvement principles and safety science.
Now, one topic that has come up is called Failure Modes and Effects Analysis, or FMEA. This is something that was first dreamed up by engineers for military equipment at NASA, but now it's being applied to healthcare. So let's take a quick look at this in your study guide, just so you've heard of it. The basic idea behind failure modes and effects analysis is to proactively, systematically evaluate a process to identify how it might fail, and then to assess the impact of different types of failure in order to identify the parts of the process that need to change the most. So it's not just what can fail, but which failures are the most serious and the most likely, and which parts need to be fixed. So first, you're going to list all the steps in the process. Then you identify the various failure modes, basically asking what could go wrong. Then you're going to drill down and identify the potential causes for each of these failure modes, asking why would the failure happen. And then finally, you identify the effects of these failures. You ask, what are the consequences of each failure? So, for example, say you were asked to evaluate the process of implementing contact precautions in patients with C. diff colitis. Well, you start by listing all the steps in that process. So first of all, the patient has to be tested for C. diff. Then the lab has to notify the doctors and nurses of the lab result. Somebody has to order contact precautions. Somebody has to put up the signs on the patient's door and put out the gowns and gloves. And then the people that enter the room have to actually wear the gowns and gloves and then dispose of them properly. Then you would list the failure modes, such as the patient never gets diagnosed, or the patient gets diagnosed but the contact precautions aren't ordered, or the staff doesn't follow proper contact precaution procedures. And then for each of these modes, you could have several different causes. For instance, for the failure mode of staff doesn't follow procedures, maybe the sign wasn't posted, so staff didn't know that they were supposed to wear gowns and gloves. Or maybe they looked for the gowns and gloves, but they couldn't find them, so they went into the patient's room anyway. Or maybe they weren't trained on how to wear the gowns and gloves, so they didn't put them on properly, or they didn't take them off properly and they contaminated themselves, or they didn't dispose of the gowns and gloves correctly. So for a single failure mode, there could be several failure causes. And then you try to determine what the effects or consequences of each failure would be, and which ones are most dangerous and which ones are most common. So if a failure is really dangerous or really common, it should probably be fixed before something that is rare or relatively benign is fixed. So that's failure modes and effects analysis. Let's briefly talk about medical malpractice. There are 4 basic elements of a malpractice claim. First, the physician has to have a duty to provide medical care to the patient. You can't sue me for medical malpractice because I'm not your doctor. I have no duty to provide you with medical care as of this moment. Then you have to prove that the physician breached that duty and that the patient suffered harm or injury from that breach of duty. And then there has to be some kind of damage that was suffered as a result of the harm or injury, whether it was physical damage or emotional damage or maybe financial damage by loss of income or whatever. And in general, the biggest risk factor for being sued for malpractice is the lack of a good doctor-patient relationship. In general, patients don't sue doctors that they like, that they have a good relationship with, even if that doctor makes a mistake. All right, that's it for our ethics discussion. Now let's go ahead and do the end-of-session quiz. We've provided several more ethical situations for you to consider, and as we talk through them, it should help you kind of prepare for the kinds of things you're going to need to be thinking about when you come across these on your test. The first question says, a 68-year-old man is diagnosed with incurable glioblastoma. It's one of the most common brain tumors in adults, and it's one of the worst. Life expectancy is 6 months or less. His family tells you, the doctor, not to tell the patient. So how do you handle this situation? Well, you need to assess whether or not telling the patient would have a negative effect on his health. It's up to you as a physician to make that determination after talking to the patient. And if telling him would have a negative effect, then you wouldn't tell the patient. But it's not the family's decision. It's up to the doctor to determine how this is going to affect the patient's health. Most of the time, you're going to wind up telling the patient, or at least ask him if he wants to know. But if you tell the patient, we're still waiting for the test results, but what would you do if the results are positive? The patient's response is, if I have brain cancer, I'm just going to go home and shoot myself. Obviously, in that case, the news will negatively affect this patient's health. The family's probably right that it would be best that he not be told. So in that scenario, you wouldn't tell the patient. Next, a patient had made it clear to you on previous visits that if something should happen to him, he would not want surgery. The patient now comes to you with a condition that requires surgery, and because of his condition, he's incapable of providing for you his present feelings on the matter. His friend relays to you that the man has told him numerous times that he does not want surgery. And his wife later shows up and tells you to do everything you can to save her husband's life, including surgery. So what should you do? So here we're dealing with substituted judgment. What does the patient want? The
patient does not want surgery, regardless of what the wife is telling you. They've given you two different sources saying the patient doesn't want surgery. So the correct answer here is do not perform surgery. Now, in the real world, how do you go about this? Well, you might have to go to court and present evidence that the patient didn't want surgery, including the friend, including your previous notes on your chart. And then the court would be able to say it's obviously the case that this patient did not want surgery. So substituted judgment means you're doing what the patient would want. It's just a matter of how you come by that knowledge. Next, how should you handle a situation where you smell alcohol on a physician's breath while that physician is practicing medicine? So you notify the physician's superior. Is it your responsibility to talk about this with the physician? No. But you do have an ethical obligation to tell somebody. So you figure out who the physician's superior is, and then you tell him. If it's a medical student, you tell the resident on the team. If it's a resident, you tell the attending on the team. If it's the attending, you tell the head of the department. Next, a 36-year-old woman has a first-degree relative who had breast cancer at age 40. You recommend a mammogram, but she refuses to have one because she says it's too painful. So what do you do?
First of all, you want to investigate whether there's something that you can do to make the exam less painful, more comfortable. And second, you're going to discuss the risks and benefits and alternatives, including the risks of not having the procedure, and then document that discussion and the patient's choice. Patients can decide what they want to do with their own bodies. If the patient doesn't want to have a mammogram, you just need to make sure to document that you discussed it with her. That way, if she comes back with breast cancer 5 years later, she can't claim, well, my doctor never told me I would get breast cancer if I didn't have a mammogram, because it's in the chart that you had this conversation. Next, you find yourself attracted to your 24-year-old patient. How do you handle the situation? Well, basically, you stay professional. In general, it's unethical for you to date your patients. Now, there are lots of different opinions out there about times when it might be acceptable to date former patients, but in general, it's a bad idea. So just stay professional. Now, do you have to terminate the professional relationship? Not as long as you can stay professional. And then you also want to consider having a chaperone in case there's any allegation of flirting or inappropriate behavior down the road. So consider a chaperone. But you don't have to terminate the relationship as long as you can stay professional.
Last one. A 72-year-old man in the hospital with an MI refuses to take his aspirin on the grounds that it makes him feel funny. So what do you do? Well, just like the mammogram scenario earlier, you should discuss the risks and benefits and alternatives and then document that discussion. You're going to need to educate the patient about why you're recommending aspirin. Say, if you don't take your aspirin, your likelihood of having another MI is greatly increased. So discuss the risks and benefits and alternatives, and also educate and encourage your patient to stick with the plan. Another possible correct answer would be to investigate the patient's symptoms. Maybe he has aspirin-sensitive asthma, and he ought to be on clopidogrel instead of aspirin. But ultimately, the patient has the final say about what they do with their own bodies, even down to which particular pill they're taking. But whatever you do, just don't get frustrated and refuse to treat the patient. That's certainly not the answer they're looking for. Just because the patient refuses one particular part of your plan of care doesn't mean you should ditch the entire plan of care or fire the patient. You can work with the patient, determine what you can do for the patient.
That's it for the end of session quiz in medical ethics. I'll see you next time.